I just want to be respectful of everybody's time. For those of you that have joined us, that's just awesome. So, good evening and welcome. My name is Connie Snyder, and I'm a First Link coordinator in the Saskatoon Resource Centre. And it's my pleasure to welcome you to the Alzheimer's Society of Saskatchewan Evening of Education Pain Management for People Living with Dementia. This evening, we hope you learn about the relationship between dementia and pain, how to recognize pain in a person with dementia when they may no longer be able to communicate that with words, learn about a few resources that are available in Saskatchewan for pain management, and learn about the great research Dr. Tupper is doing in this field. Before we begin, I'd like to take care of a couple of housekeeping items. First of all, we are recording tonight's session, and so it will be available online at a later date. Just a note to those of you that are attending, none of your names will be shown as part of the recording. Along with the Zoom link for tonight's session, you should have received a copy of the presentation and a copy of the Pain Matters booklet. There are additional resources available on our website, and Dr. Tupper will also reference a few others. The formal presentation will be about an hour or so, and we'll follow that up by with a question period. So please type your questions into the Q&A spot on the bottom of your screen. You should see a button that's marked Q&A, not the chat, but Q&A. You feel free to put your questions in there all evening if you like, or hold them till the end. We do have a couple of moderators who will read, summarize, and present these questions to Dr. Tupper at the end of the presentation. We do ask, though, that you keep your questions relevant to the topic that's being presented tonight. And if you have other questions, don't hesitate to reach out to the Society staff at one of the 7 resource centers across the province, or by calling our dementia helpline. I want to also thank our sponsors for this evening of education. SGI is our major sponsor, and we are supported by the SaskTel Telcare and Riverbend Crossing. So now I'd like to introduce tonight's speaker. Dr. Susan Tupper is a strategy consultant for pain quality improvement and research for the Saskatchewan Health Authority. She is a licensed physical therapist with a PhD in community health and epidemiology. Susan's role with SHA includes research, program planning, clinical standard writing, and education for healthcare work providers, trainees, and the public. Her research examines clinical interactions about pain for those with chronic health conditions, education on pain and exercise, and virtual reality for pain education. Susan is the co-chair of the Sask Pain, a nonprofit charity that aims to improve pain management in Saskatchewan. Please join me in welcoming Susan.
Thanks, Connie. Applause of one, it's appreciated. So thanks so much. I really appreciate the Alzheimer's Society's invitation to come and present and talk about pain. Anytime I get a chance to talk about pain is an exciting day for me, because that really shapes my world from day to day. So I appreciate this invitation. Let's see if I can get my slides going here. So as Connie mentioned, I'm going to be talking for about an hour. I'm going to start off talking about some of the relationships between dementia and pain, and then talk about ways to recognize pain. So I'll give some tips on better ways of asking about pain for people who can provide a self-report, and then different behaviors that people may express or demonstrate when they experience pain if they're not able to self-report, and how that might be used to recognize pain in people. And then I'll talk about pain management more generically and kind of a framework for planning pain management. And I'll point you towards some resources where you can find information on treatments and available information about pain management in Saskatchewan. And then I'll finish up by talking about a research program that we've been doing over the past just over a year now to develop some pain education resources for family caregivers who care for people living with dementia. And so I'm excited to share some of the early findings of that research. So I'm going to start off talking about how people conceptualize or think about pain. And some of the most common beliefs about pain can be traced back to a French philosopher by the name of René Descartes, who wrote a very large book in the 1600s where he described basically his understanding of pain at the time. And there were some definite benefits to the way he proposed pain, but then some drawbacks as well. So I'll talk a little bit about those. So you may have heard of René or Descartesian dualism, and that's where he proposed that the mind and body were split, they were separate. So all of the essence of the mind, the thoughts, the feelings were put more in kind of a spiritual sense. They were ethereal, they were intangible, but the body was more considered like a machine and functioned like a machine. And interestingly enough, Descartes put pain into the realm of the body as opposed to the realm of the mind or emotions or the spirit of the person, which was a shift in thinking leading up to that. And so Descartes' proposal that pain was a function of the body really led us to have a better understanding of the nervous system. And he proposed back in the 1600s a very rudimentary model of the nervous system where he said there were these tubes that ran through the body, and basically, as the picture demonstrates, if you put your foot in a fire, a little piece of fire would travel along the tube and up to the brain and tell you that that there was fire on your foot, and then you could react to that. So this gave us kind of a rudimentary understanding of the nervous system and really promoted kind of a greater understanding of what might be happening. And of course, lots of research has been done since then. So we now have a much more advanced understanding. We certainly don't understand everything, but we have a much more advanced understanding of the nervous system and how pain is produced. Some of the drawbacks of the Descartesian dualism or common misconceptions that come out of thinking of the body as a machine and pain as being part of the body is that people believe, and this is a common belief today or common misconception of a lot of people today, that pain is only a signal of problems with the body tissues, and that somehow pain should be proportionate to the amount of tissue damage that we have. So this leads to some common problems. If, for example, a physician or a physical therapist is looking at someone trying to understand what's the explanation of their pain, and they can't find anything on their clinical exam or the MRI, or they can't find enough to explain the amount of pain that somebody's having, they may say, you know what, there's nothing wrong with you, it's all in your head. And then, of course, the person blames themselves because the clinician doing the assessment can't find the reason for the amount of pain that's being experienced. Of course, we have other interesting conundrums, things like phantom limb pain, where the person doesn't have any body tissues at all, and yet they have this sensation of pain in the missing limb. So we have both extremes where we have a lot of pain in the absence of tissue damage or the absence of any tissues at all. But we also have the opposite, where we can have really quite severe pathologies and no pain at all. So both of those kind of really mess with our understanding of pain as being a signal only of tissue damage. One of the other common misconceptions that comes out of this belief is that people think that the only way to fix pain is by fixing what's wrong with the body. And then if you have a disease like arthritis, where you might not be able to get rid of the disease, you figure that, you know, there's nothing that can be done. And so you have to just live with your pain. And many times people are told that by healthcare providers. You know, there's nothing else I can cut out of you. There's nothing else I can do for you. You're going to have to learn to live with your pain. And so people really think that it's all about fixing the body. And so that unfortunately really limits the types of treatments that people are willing to look at. So I wanted to share a really interesting study that was done just over a decade ago by an Australian and an Austrian researcher. So Lorimer Moseley is an Australian physiotherapist who conducted the study, and I think it's a really interesting way of demonstrating how what we think influences our pain. So what they did is they recruited about 30 people to take part in this study, and they applied a very cold thermal probe or stimulus to the back of the hand of these research participants a number of different times. Every time the temperature probe was put on the back of their hand, it was the same temperature. It was always minus 20 degrees Celsius, so painfully cold, but not enough to damage the tissues, but painfully cold. But they manipulated the situation a bit, and they told participants that the temperature of the stimulus would range from either very, very cold through to cool, through to warm, all the way up to very hot. And they would be warned of whether it was cool to cold or warm to hot by a color. So the temperature probe would be put on either at the same time or just slightly delayed. And people, when the red light was shown, people were told that's going to be warm through to hot. When the blue light is shown, it's going to be cool through to very, very cold. And people needed to rate how warm or cold it was, how bothersome it was, how painful it was, and a number of different things like that. So interestingly enough, when the red light was paired with the very cold stimulus and people were told it's going to be warm through to hot, people rated it as much more painful than when the cold or the blue light was shown and they thought it was going to be cool. So of course, these are Australian participants. And so I've always thought it'd be interesting to redo this study in Saskatchewan and see whether there's no difference between hot and cold, or maybe we prefer the heat to the cold and we fear the cold more than the heat. But at least for these participants, what they thought about the potential harm of heat was that it should be more painful, and they rated it as much more painful, a 6 out of 10 on a 0 to 10 scale compared to about a 3 out of 10 for the stimulus that was paired with the blue light. So that shows that it's not necessarily the tissue stimulus that's causing the differences in pain perception, but it's more about what people are thinking. So I'm going to explain how this works just very briefly. So throughout our body, this graphic here on the right is an image of a brain and a spinal cord and some nerves running out to the tissues. So throughout our body is a network of specialized nerves that carry information about threat and potential harm to the body. And these are called nociceptors. So that's your new word for the day. Make sure you toss your hair when you say nociception, because big words are fun. So these nociceptors will detect whenever there's sufficient thermal, so too hot, too cold, or chemical stimulus like inflammation, or mechanical stimulus like a tissue stretch or crush or a cut. So any of those types of stimuli will activate those nerves, and they will send a signal up to the spinal cord. And at the level of the spinal cord, there's modulation that happens. So what I mean by modulation is that at the level of the spinal cord, before anything even goes up and reaches the brain, the spinal cord will basically make decisions. It's like an extension of the brain, and it will make decisions as to whether that signal is important and needs to continue on up to the brain, or whether it's not important and it can be shut down. So at the level of the spinal cord, there's other information coming in from other types of nerves. So for example, nerves for light touch. You know, if a child bumps their elbow and the mom kisses it better and you know, rubs it a little bit, it actually will send some messages along different types of nerves that will block those nociceptive nerves from sending the signal up through the spinal cord and up to the brain. So there's modulation that happens at the spinal cord from other nerves coming in, but also from nerves coming down and other chemical messengers that come down from the brain. So lots of modulation at the spinal cord. If the conditions are right, the signal will carry on up to the brainstem, and same thing will happen there. There's lots of modulation that happens at the brainstem, information coming from higher centers of the brain, information coming from the spinal cord and between different areas of the brainstem to modulate that information. And then kind of a relay center, it will send it off to about 20 different areas of the brain to basically form the experience of pain, that unpleasant sensory and emotional experience. So different areas of the brain that are related to the development of emotions, but also parts of the brain that determine where on your body you're feeling the sensation. So that's actually determined by your brain. It's not determined by your body tissues. Whatever part of the brain is being activated is where you'll feel that sensation, whether it feels sharp or dull, what you think about it, how you relate it to past experiences, what it means to you. And of course, the brain is not just sitting there passively waiting for this information. The brain is extremely active all the time, taking in what you're seeing and what you're hearing, what your social context is, what your thoughts and emotions are. And those areas of the brain are constantly sending those signals down to the brainstem and down to the spinal cord to basically modulate the amount of information coming in and what to do about it. So of course, when you think of pain and whether or not it's related to that body tissue damage, that's only one tiny piece of information that can be either stopped or amplified anywhere along the system. So interestingly, chronic pain is usually related, it could be related to ongoing tissue pathologies and problems in the tissues, but chronic pain can also be related to changes in how the nervous system, especially the central nervous system, the spinal cord, brainstem, and brain, how those function. And so you can get circumstances where people have ongoing pain, even though there's not really a good tissue reason for them to have pain. And of course, we don't have any good diagnoses in the clinic to look at that and to say, oh yeah, you've got that, the changes in your central nervous system happening. We can ask questions from people and we can do a couple of clinical tests, but we don't have MRIs or CAT scans or anything like that that can really identify when those changes in the nervous system are happening to cause chronic pain. So that's why you sometimes get that mismatch between the amount of tissue damage and the amount of pain that somebody's experiencing, especially with chronic pain. So focusing now a little bit more on dementia, the general prevalence of chronic pain in the population is about 1 in 5 people that lives with frequent bothersome pain that they experience on a near daily basis. And so with dementia, of course, pain prevalence increases as we age. So people over the age of 65, there's almost half of them that live with frequent bothersome pain. But interestingly, it's a little bit more frequent and more prevalent with people who live with dementia. So about 64% of people living in the community who also have a diagnosis of dementia or cognitive impairment, that's kind of a pre-diagnosis of a type of dementia, about 64% live with frequent bothersome pain. So quite a bit higher than the population who doesn't live with dementia. In long-term care homes, it's even more frequent. So about 79% of people live with frequent bothersome pain that interferes with their activities. So persistent pain, or pain that is ongoing or frequent and interferes with activities, is unfortunately associated with accelerated memory decline. So there's good evidence, even in people who don't have a diagnosis of dementia, there's evidence that pain interferes with cognitions or your ability to do mental tasks and to remember. And so with dementia, they've noticed that if you also have a diagnosis of chronic pain and you live with dementia, that you over time will have accelerated memory decline. And also having a diagnosis of persistent pain also is associated with an increased risk of needing long-term care down the road. And for people who have a diagnosis of dementia, if pain is not being recognized, it may be misinterpreted, the responsive behaviors that somebody demonstrates when they're experiencing pain. If they're not able to communicate that they're experiencing pain, that may be misidentified as worsening dementia, and unfortunately some people are treated with either antipsychotic medications or even restraints in some circumstances. And in our research, we heard examples of those that were quite distressing for the family caregivers because the pain itself wasn't being addressed, but the behaviors were just trying to be suppressed. So of course that is not appropriate treatment for people for pain or for people living with dementia. There's been some recent research, and actually just a study published just this year, talking or looking at why people with dementia, different types of dementia, may experience more pain. And so with a couple of different types of dementia, Alzheimer's disease and vascular dementia in particular, they've noticed that there's increased sensitivity to painful stimuli. So when a painful stimuli is applied, it takes less of it to cause a painful response in people with Alzheimer's disease and vascular dementia. What hasn't been looked at yet is whether it's the brain changes or whether it's the changes in lifestyle. So we also see this increased sensitivity with regular aging as well. And they haven't, it's a little bit more so in people with Alzheimer's disease and vascular dementia, but what they haven't done is determine whether if you keep somebody physically and cognitively active and socially engaged, if that protects them from developing that increased sensitivity. So that will be an interesting area of research to take a look at over the next several years to see if we can protect people from that increased sensitivity and the pain. So I've mentioned already that how much pain somebody feels, that pain severity, is only loosely related to the amount of tissue damage that they may have, and things like chronic disease or chronic pain can increase that severity of pain. Dementia, other things can increase that severity of pain even when the tissue damage problem is not worse. But now I'm going to add an extra wrinkle into the formula here by saying that the amount of pain that somebody tells you about, or the amount of pain expression, the behaviors that they demonstrate, is only loosely related to the amount of pain severity that they're feeling. So you can get differences in how much somebody is feeling and how much pain they're expressing because we don't have an objective way of measuring pain severity. We have to ask people questions or we have to observe their behaviors. And those are both social communications. So they're influenced by the social setting, by the context, by the environment, and can either be, there can be increased expression or suppressed expression. So I think a great example of this is the 11-year-old boy in gym class who gets hit in the face with a dodgeball. It may hurt, but he laughs it off and he doesn't want to cry or display pain in front of his friends because that's a bit of a social threat for an 11-year-old boy to be crying in front of his friends. But then, of course, the end of the school day, he goes home and his mom asks how his day was, and he bursts into tears and talks about being hit in the face and how much it hurts. So that social situation really influences people's pain expression. And this can be quite confusing, particularly when someone lives in long-term care and they live with dementia, and the family might go in and have just a wonderful visit with them. And the person is expressive and communicating well and looks really comfortable and happy. But then later on, they have a conversation with the staff or the healthcare providers who are saying how uncomfortable the resident is and how they're having a lot of pain. And the family members may not have seen that. And that's because the pain expression may be different when they're with the family members compared to when they're in their usual setting with the staff in long-term care. So keep that in mind as well, that when we assess pain, that pain expression can vary even when the pain severity stays the same. So we're only able to assess pain expression. There's a few different ways that we recognize pain. So because pain is that subjective internal experience and both the sensory and emotional experience, if you can ask the person about their experience and get a self-report, that is the best way to assess pain. And even people with up to moderate dementia can self-report their pain experiences quite often. For people with more advanced dementias, we have to rely on observing their behaviors. And the best way to do this is to use a standardized tool that has been developed for pain assessment or pain recognition in people living with dementia. And there's a few really good examples, and I'll tell you about a couple tonight. If you're not able to observe those behaviors for whatever reason, you can rely on what's called a proxy report. And that's either asking a close family caregiver or a close healthcare provider who spends a lot of time with the person, preferably, who is familiar with their behaviors, both when they're in pain and not in pain, and they're able to give kind of an estimate of how much pain they're experiencing. It's better, though, if you can use the self-report or the behaviors and not rely on somebody's external observations or opinions that aren't based on a formalized assessment tool. Another way of recognizing pain is to note the behaviors in the self-report and then to perform a treatment trial, which either is medications or non-drug treatments or a combination of the two, and to see what effect that has on their behaviors or on their self-report. Quite often, we're not just relying on one of these approaches to try to recognize pain. We might rely on numerous different ways, and they all form a picture together along with the clinical assessment that the healthcare providers might do, and the whole picture. You don't want to just rely on one thing, or it's usually better not to rely on one thing. All right, so I'm going to talk a little bit about self-report, just because there's misconceptions, especially with people with dementia, where you see as dementia progresses, you can see differences in self-report. So you could ask the person living with dementia if they're experiencing any pain, and they'll say no, but then when you observe them, their behaviors show that, they look like they're uncomfortable. They might be grimacing, or they might be rocking, or showing some of those behaviors, and yet their verbal report says no. So there's different ways that you can ask about pain to try and improve the ability of the person to respond to the questions that you're asking. The first tip is how you word it. So whether you ask about pain or hurt or soreness or aching might influence the response that you get from the individual. So interestingly, what we've found in our interviews is that the word pain tends to be reserved for when somebody is experiencing a new experience or a sharp sensation. So they don't use the word pain necessarily to talk about their arthritis or their aches or their sore back, that kind of thing. They might use other words for that. So if you're asking somebody if they're uncomfortable and you ask if they have pain and they say no, then you can say, well, how about any soreness, or how about any aching, any discomfort, and see if their response changes that way. The other tip is that we don't just have to ask somebody about a 0 to 10 scale. Lots of people don't like putting a number to their pain. It's too abstract for them. And so there's different ways of asking to find out how much pain or how severe the pain is that somebody's experiencing. We can ask them to score it on a 0 to 10 scale, and that's quite often what you'll experience if you go into the hospital or into the emergency department. You can ask somebody to describe their pain with words. So is your pain mild, moderate, severe, really, really bad? So you can use a series of words that describe kind of increased severity of pain, and hopefully using words that are understandable to the person. You can use a FACES scale, and I've got the FACES pain scale revised here, a tiny little image of it on here. Where the faces, there's 6 faces in a row, and they go from kind of a neutral face up to a full facial grimace. And of course, you don't use this tool by looking at the person and seeing what face matches their face. You show the faces to the individual and ask them to point to the face that feels like what they're feeling like inside. So quite often it was a tool that was developed for children between the ages of 4 and 17, but adults of any age are able to use this tool, when especially useful when they can provide self-report, but they may not be able to vocalize or verbalize, but they can point to the face that is representative of their pain. So for example, if somebody has had a stroke and they have an aphasia, a verbal aphasia, and they're not able to give you a number, or they're not able to say how much pain they're feeling, they may be able to self-report, and they could do it by pointing to the face that feels the way that they feel inside. Another common error that we see with the 0 to 10 scale, if that's being asked, is people may not understand which end of the scale means the worst. So even though you can say 0 is no pain, 10 is the worst pain possible, sometimes people still think 10 out of 10 is the best. And I've got a short video clip that I'll show you to demonstrate this and the different ways that pain can be asked by self-report. Some of the other tips that we've learned is that if you ask somebody about pain in their whole body, it's harder for them to answer those questions. So if somebody has multiple locations of pain, and for older adults over the age of 65, about 75% of them actually have pain in more than one location. So if you're asking a generic question about pain, they may not know how to answer if their knee feels one way and their elbow feels another way and their back feels another way. So it helps if you ask them to say, you know, how much is your right knee bothering you today? Or how much pain do you have in your right knee? Or you can point to the body location if that is an easier way to communicate. So it's easier to talk about one location, and usually you pick the worst location and ask about that. It's also easier for people to talk about the pain that they're experiencing right now as opposed to a recalled score of pain. So if I asked you, you know, how would you describe your meals that you've had over the past week? Well, that would be a lot harder to explain or to describe or to give your opinion than, you know, what did you think of your supper that you had tonight? So it's easier to talk about one event. And of course, for people with dementia, the right now is what they can respond to. They may not be able to give you, you know, the past hour or two or even the past few days. So asking about current pain is the best way to go. So I'm just going to pop to that video here. Just check my time. All right, and pull up that video. Here's an example of a client who has misunderstood the direction of the numeric rating scale.
So are you feeling any pain right now?
A little pain in this knee, yeah.
Okay. Well, if we rated your pain on a scale of 0 to 10, 0 being no pain and 10 being the most pain possible, what rating would you give?
Probably 7 or 8.
Seems like a lot of pain. If you weren't experiencing any pain or discomfort, what rating would that be?
Well, I guess that'd be a 10. 10's always the best, right?
In this case, the nurse would restate what the anchors mean, or the nurse may choose to use a different scale, such as a FACES scale or a verbal descriptor scale. Let's watch.
Let's try a different way to measure your pain. Can you describe your pain using one of these words? Is your pain mild, moderate, or severe?
I'd have to say moderate. It hurts quite a bit when I move, but it's not so bad when I sit still.
All right. Oops. So that gives some examples of different ways that you can ask questions about how severe the pain is. And why that matters is that you may choose different treatments or support the person living with dementia in different ways, depending on how severe their pain is. If their pain is mild and it's not really bothering them too much, then you may not do anything about it at all. If the pain is creeping up into something moderate, or it starts to get in the way of their activities and it's starting to interfere, you know, they're thinking about it more, then you may start some non-drug approaches to care. And even when the pain is mild, you can certainly do the non-drug approaches to care. And then with moderate, if it's creeping up to a higher amount of moderate or getting into the severe, then quite often you're layering on some medication management as well, following your prescriber's advice on that. So that's one thing to consider for treatment. I'd like to talk now about behaviors that are common when people are experiencing pain. So there's been a number of different tools that have been developed to help kind of a standardized approach to assessment of pain in people who live with dementia. At the bottom here, I've got links to a great website called geriatricpain.org, where there's a couple of really good tools that have been developed. And these are tools that were developed for healthcare providers to recognize pain in people living with dementia. And so there's some training involved to develop some proficiency in being able to use these tools. But it's still helpful, I think, for family caregivers to be familiar with these tools, to know how the pain is being assessed in their loved one by healthcare providers, particularly if they're living in long-term care. And so there's a couple here that are strongly recommended by research. The PainAD and the PACSLAC2. And of course, the PACSLAC2, if you've heard of Dr. Thomas Hadjistavlopoulos from the University of Regina, that is his tool, and a really well-respected one internationally. So these tools are quite different. There's some overlap both with these tools and a number of the other ones that have been developed for assessing pain in people living with dementia. There's some overlap in the types of behaviors that are observed. So I'm not going to teach you how to use one of these formalized assessment tools, but I'm just going to talk about some of the behaviors that are common among the different tools. So the first one, and the one that, regardless of whether it's a tool that's been developed for people in the intensive care unit or, children or neonates in the intensive care, regardless of, who the population is, facial grimace or facial actions are something that are included in pretty much every behavioral assessment tool. So here's that FACES Pain Scale revised. And again, another Saskatchewan researcher, Dr. Carl von Baer, who was one of the people that developed this FACES Pain Scale revised, from the University of Saskatchewan. And so I want to talk a little bit about the facial movements that occur quite often with pain. And interestingly, these are facial actions that regardless of the age of someone, from youth up to older age, and also regardless of ethnicity, these are the facial actions that are quite typical of someone who's experiencing pain. So the first thing that you'll notice is actions in the eyes. The eyes tend to squeeze shut, and the brows squeeze together and lower down, so you get a bit of a bulge between the eyebrows. And then you see the cheeks start to raise, and as the cheeks raise, you get an increased crease between the nose and the cheeks, the nasolabial furrow it's called. And then you'll see changes in the mouth as well. So you can get a vertical or a horizontal stretch of the mouth until you get that full facial grimace. So you can see how it kind of grades itself and gets progressively more of the facial components that are involved. So those are facial actions that are more typical of pain. They don't necessarily confirm that someone is feeling pain, but they are more typical of changes in the face that occur with pain, as opposed to surprise, where the eyes might fly open, or fear, where the eyes open and the eyebrows raise. With pain, you typically get more of the face kind of closing down like that. Other behaviors that may indicate pain, and again, I want to emphasize the may, because there's other reasons why people may demonstrate these behaviors, but you sometimes get changes in the breathing, and you can either see breath holding or hyperventilation. So the person, as they're moving, they may kind of suck in their breath and hold their breath as they're moving, or you may see that they start to breathe a little bit faster. And of course, they can also flip-flop between breath holding and hyperventilation as well. Quite often you'll get negative vocalizations, so grumbling or moaning, some cursing, grunting, crying, or a gasp kind of sound. So those are all common, and the person living with dementia may have a very unique sound that they make when they're experiencing pain, whimpers, things like that. Other behaviors that you see are changes in body language or muscle tension, body tone. So you might see the shoulders start to shrug up or curl in. You can see guarding of the area that's sore, or the person is touching it a lot. They may limp if they're able to ambulate. You might see, with more severe pain, you might see the fists start to clench. Or you might see the person flinch if somebody's reaching out towards them. You can see that they pull away, or they could strike out as well. They might rock or pace or fidget as well, and just have kind of that increased agitation and energy if they're experiencing pain as well. And again, I want to emphasize that you can still see some of these actions even if the person's not feeling pain. But when you put the whole picture together of some of the changes in the face, the changes in the breathing or the vocalization, then you might begin to think that this may be indicating some pain in the person. Another thing you'll see is kind of the change in the behaviors or the consolability of the behaviors if they're able to be distracted. So if you're talking to them and they stop their agitation, it doesn't mean that they don't have pain, but it may be a lower level of pain if they're distractible, or if those behaviors like the muscle tension or the moaning, if they settle quickly if the activity is stopped. And that's compared to somebody with more of a severe pain where it's the behaviors don't settle quickly. So the behaviors may continue even if the activity is stopped. So for example, if somebody's being moved from a lying down to a sitting position, and then they start to call out or cry out or become very tense with that movement. And then if you stop the activity and they settle and they relax, then it may be more of a lower level of pain. But again, things like, the body tension, it could just be more of a fear or anxiety. If they're being rolled on the bed, they may be nervous about falling, things like that. So again, these are behaviors that are common, and you need to take all of these, think about all of them together, as well as kind of the clinical history of the person in all together in order to make a decision as to whether or not the person's feeling pain. Other things that you might see are changes in their appetite, usually a decreased appetite if they're experiencing more pain, particularly any dental pain. They're not going to be wanting to eat very much. You may see changes in their activity, and I mentioned before with some of the body tension, you might see an increase in activity, but you may also see decreased activity or avoidance of activity. The person doesn't want to get up, they don't want to walk, they don't want to be engaged in any of their usual activities. They may not want to hang out with people anymore and spend time with family or friends. They may avoid touch. So if they're normally okay with having their hand held, but they're pulling away and they don't want to be touched, that may be an indicator of some discomfort. You may see changes in their sleep. Either they're napping more, or their sleep is more interrupted and they're not able to sleep as much. And quite often you'll see changes in mood as well, where they're a bit more withdrawn and a little bit grumpier or sadder, and crying more often. And in some cases, in rare cases, you also see self-harming behaviors where the person may bite themselves or hit themselves. We certainly heard stories of that in our interviews with family caregivers, people hitting their head and that kind of thing. When they were experiencing pain. It's really important for family caregivers to be engaged with the healthcare team and to be able to communicate, to be given the opportunity to communicate with healthcare providers to contribute to the decision-making around pain. Family caregivers who spend time with the person who lives with dementia often pick up subtle cues that healthcare providers may not recognize. And we heard all sorts of different ones that people identified of just kind of a flatness in the eyes or a change in their look. And it's something that the family caregivers we interviewed said that they worried that the healthcare providers just wouldn't recognize it because it was just such a subtle change that cued them as to when pain was starting to get in the way. And they reported that, quite often what they noticed in long-term care homes is that only the really severe pain behaviors were being recognized, and pain was being missed at lower levels. So that's why it's so important for family caregivers to be able to basically train healthcare providers about the ways that their loved one with dementia expresses pain. So moving on now to treatment, it's important to recognize that there are different types of pain. And I talked a little bit about this when I had the diagram of the nervous system on, but there are basically three main types of pain. You may have heard of acute and chronic. And acute and chronic are really just how long the person has had pain, but you can have different underlying mechanisms of pain, no matter whether you've experienced it for a few days or several decades. So these are the three main mechanistic types of pain. So nociceptive pain is and it can either be of the body tissues or the somatic tissues like the bones, muscles, joints, or it can be visceral tissues like the heart and the gut. And so nociceptive pain, there is that mechanical, thermal, or chemical stimulus that is driving that pain. And it tends to be more straightforward and easier to treat. Neuropathic pain arises when there's an injury or a disease or an infection in one of the nerves, either a peripheral nerve or a central nerve. So things like shingles is a peripheral neuropathic pain. You can get that with shingles, or a post-stroke pain is an example of a central neuropathic pain. Multiple sclerosis, Parkinson's disease, spinal cord injuries, any pinched nerves anywhere in the back and causing pain down the leg, all sorts of things. Carpal tunnel syndrome can give you a peripheral neuropathic pain as well. Diabetes, people often experience burning in their hands or their feet related to neuropathies because of changes in their nerves with diabetes. So all sorts of different types of neuropathic pains. And then there's this relatively new term just over the past year or so called nociplastic pain. And that's the pain that I described earlier, where there's changes in how the spinal cord and the brain process information. So you get kind of a heightened sensitivity to stimuli, and that's called nociplastic pain. So for people who live with chronic pain, they may have any of these, well, nociceptive or neuropathic in particular. With chronic pain, you can have all of these. You can have one of them or all three of them combined. And of course, the longer you've lived with pain, the more likely it is that you develop a nociplastic type of pain. With these three types of pain, in particular, the medications that are used to treat these three different types of pain is very different. So with a neuropathic or a nociplastic pain, your first line medications are actually antidepressants and anticonvulsants, as opposed to a nociceptive pain where things like acetaminophen or an NSAID, an anti-inflammatory, may be your first line approach to care. And of course, the treatments that you would apply, the non-drug treatments, would be quite different depending on the type of pain that you have. So unfortunately, with people who live with dementia, in order to differentiate the three different types of pain, it requires people to be able to describe their pain and also tell you where it is in very specific detail. And so that's something that's quite difficult for people with more advanced dementia. And again, I have to emphasize how important it is for family caregivers to be involved and to share that history of saying, you know, my dad used to describe his low back pain, and he would get pain down his leg when he sat too long. So that type of history is so important for family caregivers to share about the person living with dementia if they're in a long-term care home, and making sure that they advocate and share the stories about the person who lives with dementia and their pain history, so that it gives the healthcare providers and decision makers more information about the different types of pain that the person might be experiencing. So when we talk about treatment for pain, again, I mentioned that quite often when you talk about pain treatment, people automatically think of medications or surgeries and things like that. And of course, those can play an important role in pain management, but they're certainly not the only thing. And so what we propose that people look at is what we're calling the 4 Ps framework. So of course, considering medications and prescribing, getting the right type of medication for the type of pain that they have, and you know, may use oral or topical or other approaches to apply the medications. Physical interventions include things like exercise or just movement, things like being in a rocking chair, or activities that are fun like gardening. It can include things like massage, either a self-massage or a massage therapist, or even gentle touch. Warm and cold applications can also be a physical approach to managing pain. Warm blankets or hot, microwaved hot pads, things like that. Not electric. Don't use electric heating pads because those can cause some burns as well. So try to avoid those. But those bean bags that can be heated, or a hot water bottle, as long as it's appropriately wrapped and not too hot on the skin. Things like acupuncture. There's an electrical device called the transcutaneous electrical nerve stimulation, or TENS, that can be applied. You may have seen the commercials for the Dr. Hose where the muscles are twitching. TENS does not make the muscles twitch, at least if it's put on correctly. It doesn't make the muscles twitch, but it puts in that gentle buzzing kind of stimulation that can interfere with the signals from the nociceptors traveling to the spinal cord. Other things like physiotherapy or chiropractic treatment may be appropriate for some people as well. Psychological interventions can be any wide range of things: music therapy, cognitive behavioral therapy, different relaxation strategies or breath control, even human interaction or pet therapy, either a real animal or one of those, you've probably seen some of those mechanical animals that purr when you pet them. So those electrical devices. Things like aromatherapy or distractions, which could be anything from watching a ball game or watching an entertainer come into a long-term care home. And of course, with our research, we're looking at the role of virtual reality, either as a way of creating a distraction or creating an opportunity for people to have that immersive experience where they can, be in Cranberry Flats or on a farm with some horses and watching the horses be groomed or ridden around a pasture. And then preventative strategies include things like the environment, making sure it's a dementia-friendly environment, not too much noise, not too much change that's happening, consistent faces and places, and frequent positioning and repositioning in making sure the person's not sitting in one position for too long. Working at home and being in front of Zoom all the time, we all know how uncomfortable it can be to sit for a long period of time. So that frequent repositioning is really important. Other things like braces or mobility aids to help the person move around, or wedges or splints as well can help with proper positioning and prevent the onset of the stresses that to the body tissues that can cause some pain as well. So treatment options will really depend, what's available to the person really depends on their capacity for engagement with the treatment. And that can be affected by their cognition and attention, their memory, fatigue, their physical capacities as well. Depression can influence their ability to engage with treatment, and even pain can interfere with that. So for people who have low capacity to engage with treatment, we really rely on passive treatments like medications, heat and cold, gentle massage, distraction, those kinds of things. But for people who have a higher capacity for engagement, we can add physically and cognitively active interventions like exercise, cognitive behavioral therapy, mindfulness practices, and other things like pain education or acceptance and commitment-based therapies. So in order to find out information about what's available for pain in Saskatchewan, I encourage you to take a look at the Sask Pain website. And so Sask Pain is a nonprofit organization that has been around for a couple of years, and we just redesigned our webpage. And you can find information at www.saskpain.ca. And there's a page for people who live with pain, and a page for healthcare providers, and then a place where you can find information on the research that's happening in Saskatchewan about pain. Some of the research, there's some that still needs to be added to the website. But you can find information about, where to get information about exercise, or where to get advice on medications. So for example, if you're not sure if you're taking or your family member is taking the right medications, or you're not happy with the side effects that they're experiencing, or you're wondering if, something like a cannabis might be an appropriate addition to the person's medications, of course you want to talk to your prescriber. But also you can talk to pharmacists at the Medication Assessment Center, and there's links for that at the SaskPain website. And you can find where there's multidisciplinary pain treatment programs. There's one in Regina, and the Medication Assessment Center has an opioid pain service, an interprofessional opioid pain service with multidisciplinary healthcare providers involved. And so we have Saskatoon and Regina, some clinics. There are interventional clinics with anesthesiologists as well, and information there about that, information on different psychological interventions and support groups. And so, of course, if you're wanting more information on something, you can email us at info@saskpain.ca, and hopefully we'll be able to answer your questions as well. So I encourage you to check out that website. I just wanted to highlight on one of the pages, this is about halfway down the Living with Pain page, where I've put up the series of brief videos about assessing and managing pain in older adults. So there's a series of 13 videos that range from about 6 minutes to 13 minutes, where you can find information on the language of pain. And that clip, the video clip that I showed earlier, is from the language of pain. You can learn more about different pain assessment tools, learn more about the 4 Ps of pain management. And there's 3 videos on different medications for the different types of pain, and information on physical treatment strategies, psychological and preventative strategies as well. So hopefully those will be informative for you, and they're just links to YouTube videos that we've posted. So I encourage you to take a look at those. I also wanted to highlight CADTH as a wonderful resource for information both about pain and about dementia. So if you haven't checked out CADTH yet, this is it stands for Canadian Agency for Drugs and Technology in Health. What they are is a federally and provincially and territorially funded organization that will synthesize or bring together evidence. So it pulls together all the research studies on a topic and describes it in a fairly easy to understand way. They summarize the different types of studies and the results from them, and what the evidence is. So I just randomly typed in cannabis for dementia and found that they have a fairly recent, a 2018 review of the guidelines and effectiveness of cannabinoids for addressing behavioral symptoms in adults with dementia. So they also have an excellent pain bundle as well. So you can just type in chronic pain bundle and you'll get lots of information. And I just recently worked with CADTH to develop some patient information materials about non-drug treatments for chronic pain. So there's a poster and there's 3 patient information handouts that describes the evidence for psychological, physical, and preventive strategies for chronic pain management. It's not specific to dementia, but it's interesting information nonetheless. And a source for you to find what the research is on different topics. So now I wanted to just briefly talk about the research study that we've got underway, and we've received funding from SSHRF and the Center for Aging and Brain Health Innovation and the College of Medicine at the University of Saskatchewan. And here's our partners on our team members on our research. So we've got a wonderful PhD student, Kirsty Gibson, and some other names that are probably quite familiar to you. Tracy Danlish and Laycock is one of the behavioral consultants with SHA for long-term care homes. Rosalind Compton and Lorraine Holslander are both with Faculty of Nursing, and Paulette Hunter is also a behavioral consultant with SHA and a faculty with St. Thomas More College in psychology. So, and then we have our partners, we're working with a company to develop some virtual reality videos, Luxonic Technologies, and of course the Saskatoon Council on Aging and Alzheimer's Society of Saskatchewan have been super helpful in supporting our research and helping spread the word about what we've been finding, but also making announcements about when we're recruiting participants. And we'll be recruiting more participants for the second phase of our research once COVID settles down a little bit. So our questions that we looked at, number one, were what are family caregivers' experiences caring for and identifying and managing pain in persons living with dementia? And then we also looked at what the pain management knowledge needs and learning priorities were, and perspectives on learning contexts, such as virtual reality. So I'm going to focus just on this first question and talk about that and what our findings are with that. So we interviewed family caregivers, 29 family caregivers, and we were able to include 7 people living with dementia in the interviews as well. So of course we invited, anytime we did an interview, we invited the family caregiver to invite the person who lives with dementia to take part in the interview as well. And we met with both of them at the same time and really got some great information. So our interviews lasted anywhere from 35 to 90 minutes, and we audio recorded them, transcribed them, and then analyzed them. So the 3 key themes that came out of these interviews, the analysis from these interviews, and I'm going to go into more detail on each of these, but number 1, caregivers take on multiple roles related to pain management. Number 2, family caregivers experience both inter- and intrapersonal conflicts that can interfere with pain management. And number 3, that healthcare providers and health services were perceived both as barriers and facilitators to pain management. So regarding the multiple roles, the 3 roles that family caregivers identified were that they were advocates. They were advocates for getting a diagnosis to find out what was going on, what was causing the pain, but also advocating for a care plan to be developed and also a care plan to be followed, because they found that when people were, the person with dementia was traveling between different care sites, that sometimes the pain management care plan wasn't being followed. For example, if it was everything was under control in the long-term care home, but then the person had to go into acute care, sometimes the pain management got missed in acute care, or vice versa, where they had to kind of advocate and make sure that the pain management was taken care of and the plan of care was being followed. They also described roles of being knowledge brokers and basically being the go-between between different healthcare providers, so between specialist appointments and the family care, the family physician, and also a knowledge broker between healthcare providers and other family caregivers as well. So they found themselves being the person that was communicating and telling everybody about what was going on and what decisions were being made. And they also described being a helper with day-to-day pain management, everyday things like reminding the person living with dementia to take their medications or helping them to set up some non-drug treatments as well. Regarding the inter- and intrapersonal conflicts, there were conflicts related to the balance between freedom of choice versus safety and doing what is best for the person with dementia. So for example, do you allow the person to miss their medications if they don't want it? Do you allow them that freedom of choice, or do you try to get them to take their medications even though they don't want to, knowing that that's best for the person? Or, if the person living with dementia doesn't want to be socially or physically engaged in different activities, but that being physically active is good for them, what's the balance there, and what's the right decision of allowing the person to do what they're saying they want to do versus trying to convince them gently and how to effectively convince them to do what is best for them or what you think is best for them. There was also family caregivers described conflict between family members about treatment choices, where not all family members either recognized that the person was living with pain or agreed with the treatment choices that were decided by the healthcare provider teams. And this was in particular, we found this related to opioids, that some family caregivers were really afraid of having their family member on opioids, but that was what was being advised and agreed on by the healthcare provider team and the primary family caregiver, but other family members were unhappy about that choice. Family caregivers also relayed that they felt guilty about the past and about pain management not being optimized early on, and also expressed fear of the future as well, of what would happen to them and to their family caregiver down the road when there was pain. And in our family caregivers, about half of them reported quite severe pain as well. And so it was not just pain of the person living with dementia that was fear invoking, but what would happen to themselves and who would take care of the person living with dementia if their pain got to the point of them not being able to support the person. They also expressed that they had difficulty recognizing pain and communicating with the person living with especially advanced dementia, and the difficulties with that, communicating about pain. They reported that healthcare providers and health services were barriers or facilitators. They recognized that healthcare providers were a key source of information in many circumstances, and they identified family physicians and community pharmacists and staff at long-term care homes as being a key source of information. Some of our participants also described what they found was a problem when particularly their parents, so it's adult children of parents who live with dementia, who basically didn't question their family doctor. If the family doctor would prescribe something, they basically didn't think about it or didn't question it, and they just did it. Or if the family doctor prescribed something, but the person living with dementia didn't want to take it, they wouldn't take it, but they wouldn't question the doctor, and they just wouldn't tell the doctor that it wasn't working for them. So that unquestioning trust, or the not questioning the family physician in particular, was identified as a problem for some of our participants. Family caregivers, unfortunately, also described fearing being a bother to the healthcare providers. They didn't want to, keep harassing the long-term care home staff or keep harassing the family doctor to talk about pain or to address pain. They worried about that, and sometimes they just decided it was easier just to not even bother asking. And so they would go to Google to find information, or asking a non-healthcare provider for advice instead of getting advice that's tailored to the individual. Family caregivers were sometimes treated by healthcare providers as being non-credible sources. So one participant described that they, shared information about kind of what they thought were pain behaviors, and the healthcare provider said, well, did anybody else see that happen, or was it just you? So things like that are really discouraging, and really facilitate kind of that fear of being a bother as well. So certainly a problem in that circumstance. Family caregivers also reported that they had a hard time accessing both non-drug treatments and information about non-drug treatment options, especially in rural settings, that the long-term care homes didn't necessarily have a physical or occupational therapist or somebody that could advise on, a recreation therapist and advise on the non-drug treatments. So from this, what we've concluded is that family caregivers, they all reported that they valued their roles in supporting pain management, and they found that all three roles were quite critical to ensuring well-being in the person living with dementia. What we recommend is that both in primary care, so the family physicians, as well as dementia care screening teams, include pain assessment and identifying whether people need further information about pain management when they meet with families and meet with people who live with dementia. Our family physicians and healthcare provider teams can also support that knowledge broker role by providing written care plans and treatment descriptions. So making sure that we have available information on really practical things like how long a hot pack should go on, how do you check and what do you look for to make sure that it's not too hot? How do you tell whether, a non-drug treatment is working? Things like that. We also found, and our family caregivers really encouraged us to develop some education for a healthcare provider that was specific to pain management for people living with dementia. And especially that our healthcare providers would develop communication skills and learn ways of engaging family caregivers to be involved as decision makers and as part of that healthcare team because they really do have that unique information about the person living with dementia. We also would like to develop some education materials for family caregivers on recognizing pain and how to communicate with healthcare providers about pain. So really reinforcing that role of being the advocate, and how to support that everyday pain management. So simple things like, you know, that medication packaging and labeling simple changes to that can really improve adherence to medication, what's being prescribed and what's being recommended. Other things like alerts to prompt the timing of treatment, and apps to remind them when it's time to take medications, things like that, and information on non-drug pain management options. We also really would like to advance our understanding and the inclusion of pain management in those advanced care planning discussions. So those ethical decisions that we talked about before of recognizing that there's potential for conflict over pain management, and that these discussions need to be held early, so that people know what the wishes are of the person who lives with dementia, and it's not up to the family caregivers to try and guess what the person may want. So what's next? We've developed what we're calling our learning curriculum of information for family caregivers around pain management. We've sent out our learning curriculum to 16 family caregivers and 15 healthcare providers to get feedback on the content, and we've integrated that. We've compared our learning curriculum to what's available, and we found some gaps. So we're going to be developing some new information materials for family caregivers. And we'd like to do that in collaboration with family caregivers. So co-designing those education materials with family caregivers, because that's the best way to make it so it's applicable and interesting and informative to the family caregivers, is to co-design it with them. We're also right now developing some virtual reality videos. So we've got 3 of them filmed already, and we're waiting to film 1 more. We need COVID to kind of settle down before we can film the last one. But we're going to create 1 educational video for family caregivers, basically demonstrating how to recognize pain, so different behaviors. So for people with advanced dementia, what are the changes in the face, and what are some of the changes that you see in the body, tension and the breathing and the vocalizations. And it's kind of one of those videos where it's a choose your own adventure, where a scenario is presented and then you have to make a choice, and it takes you to the next level of the video, and then you have to make a choice, and it gives you feedback about your selections. So it's more of that educational feedback type of video, and a training, even though it's just with your virtual reality headset and you don't have a teacher in the room with you, but it feels like you do, because it's such an immersive experience. We're also creating, and all of this is based on the recommendations of our family caregivers. We chose the topics of these videos based on the interviews that we held with people, and they wanted experiential videos as well that could be used for pain management and stress management as well, both by the family caregivers and by the person living with dementia. So what they asked for was a video with horses. So we've gone out and filmed with some horses, and so it's kind of this pet therapy kind of video that you'll be able to watch the video and see the horses walk around you, and see the riders groom and tack the horses. And you'll hear all the stories about these amazing animals that have most of the horses are retired, and they've had these very interesting histories. We've also taken a video out at Cranberry Flats during the summer. It was a beautiful sunny summer day, so we've got some video footage of being at the top overlooking the river and the boardwalk that goes down, and then also over at the side, more towards the edge of Cranberry Flats, and then right down by the river as well. So for people who have gone to Cranberry Flats before, that'll be a nice familiar environment, and it's a beautiful relaxing environment, and there's some geese flying around and honking, and it's really quite relaxing and beautiful. And we're pairing that with a breath control practice as well, that people can either just watch the video or they can listen in and practice some of the breath control as well. And then our third video is of a choir singing songs from the 1920s. So we've got 8 songs that we'll be filming, and of course we need COVID to settle down before we can get a choir together and do the singing. But when you put the headset on, you'll feel like you're a member of the choir, so you'll be able to look around in all the different directions and feel like you're right there and hearing the music in your ears, and you can sing along as well. We'll have the sheet music in front so people can follow along with the words and the music. And so that's what we're working on now. And as Connie described, I wanted to point out some excellent resources. So of course, the Alzheimer's Society website, if you search for these different titles, what do I need to know about caring for the person, pain matters, end-of-life care, and how does pain affect people with dementia, there's some great resources there for further reading. I mentioned geriatricpain.org before, and so you can find those pain assessment tools and more information about pain in older adults there. And then this article that's publicly available as well, I've got the link there for you, and that talks more, it's more of the science between the associations between pain and dementia for those of you who are interested in that. So then to summarize, pain unfortunately is quite common in people who live with dementia, and it's quite often misunderstood as well. Very important for us to recognize pain so that it can be appropriately managed. And so I've given you some tips on how to solicit a self-report or ask about pain, and of course some different behaviors that you can observe that may indicate that a person is experiencing pain, and just to get a better understanding of how your healthcare providers may be assessing pain, either in long-term care or in acute care if the person's in the hospital. There are multiple different treatments for pain, and of course the type of treatments that are chosen really depend on the type of pain a person's experiencing. You can find out more information on what's available in Saskatchewan at saspain.ca. And just wanted to emphasize again the important role that family caregivers play in supporting pain management, and how important it is for family caregivers to expect and demand a role in the decision-making around pain management, because you definitely have unique knowledge and can contribute quite substantially to those decisions. And so to support this, we're hoping in the next stages of our research to provide education both for family caregivers and hopefully also for healthcare providers to be able to support family caregivers in these roles. And that is the end of my presentation, and I'm going to turn it over to Connie to give the final slides, and just tell me when you'd like me to advance the slides, Connie.
All right, so thanks so much, Dr. Tupper. So folks, if you haven't already done so, please put your questions into that Q&A part on the bottom of your screen, it should be. While I just tell you a little bit about the Alzheimer's Society. We have a couple of moderators who will read, summarize, and present the questions to Dr. Tupper very shortly. Again, please just keep your questions relevant to tonight's topic. And just know that your questions may be summarized or reworded just to give us enough time to cover all the questions that might be asked. So if you have any questions about dementia or needing any support, don't hesitate to reach out to one of the Society staff at one of our resource centers here in the province, or by calling the Dementia Helpline. So I just want to thank again our sponsors, SGI, and our other supporters, SaskTel Telcare and Riverbend Crossing. Next slide, please. The Alzheimer's Society vision and mission, our world without Alzheimer's disease and other dementias, and the Alzheimer's Society of Saskatchewan empowers people to live well with dementia while funding research into prevention, cures, and quality of life. Just to point out a couple of things, we are a board-directed not-for-profit that was incorporated in 1982, and we provide support, education, and resources to people affected by many types of dementia, not just Alzheimer's disease. Also to note that you do not need to have a formal diagnosis in order to access our programs and services, although we do encourage people, and we can certainly help by providing some resources and getting that diagnosis. Next slide. Programs and services. We've moved everything to online during the pandemic and telephone support. So we do not have any in-person programs right now. However, we still are able to do family and individual support over the telephone. We also have moved a lot of our support groups to online format using Zoom and teleconference. So there's been some really benefits to COVID, I guess, if you want to look at some good things that have come out of COVID, and that is some of our unique support groups that were, for example, frontal temporal lobe dementia spouses, or our young onset spouses, or our young caregiver support group. We're now able to offer that across the province, and so people are connecting to each other throughout the province. Another one of our groups that we started only during COVID was something called Coffee and Chat. And that is something that we hold every Friday morning from 10:30 to 11:30. And it's for the person living with dementia and a care provider or partner to come and just basically have that coffee and chat with other people from across the province. We've had some really interesting conversations. I've learned a lot about cooking. We've compared puffed wheat square recipes. We've talked about Christmas planning, Halloween, you name it, that group has definitely talked about it. And so it's just, again, an opportunity to connect with other people with lived experience that are very similar to what some of you folks might be experiencing now. We also have our learning series that we have offered again through Zoom. And so our progressive learning series goes from First Steps, which is a learning series for someone living with dementia and their care partner, right up to the end of life, talking about care in the later stages. Our evenings of education, like Dr. Tupper, we had initially planned to have you in person through telehealth presenting back in April, and we're just so very grateful to you that you would agreed to come back this fall and do this presentation by Zoom. We will also be hosting our evening of education, Understanding Dementia, in the new year, so watch for stuff regarding that. We're still able to do some community presentations as well. Our public awareness coordinator has been delivering the ABCs of dementia presentations a couple of times a month to individuals or to groups of individuals. And we're able to, if we can set it up virtually, go into various meetings or organizations and do community presentations in that manner. Next slide, please. The Alzheimer's Society is part of the Alzheimer's Society of Canada Federation. And so part of that is us contributing to the Alzheimer's Society research program. And so since 1989, this group across Canada has invested over $59 million in dementia research. No, it's not a lot of money when you talk about, the world of research. We wish we could be providing more money into dementia research, but it certainly is a start. And so that is a program that the Alzheimer's Society of Saskatchewan does contribute to. The research that is done through the program is biomedical. So that's looking at the clinical side of things as well as quality of life research. So things like the virtual reality and those are virtual videos and things like that to provide better quality of life for somebody. Next slide. So not only in Canada do we support research, but right here in Saskatchewan, Dr. Daryl Mousseau has been the research chair, partially funded through us, the University of Saskatchewan and the Saskatchewan Health Research over the last 10 years, where he's been doing some research looking at the connection between Alzheimer's disease and depression. We also every year fund a graduate student through the Center of Aging and Health at the University of Regina. Next slide. We would be remiss if we didn't talk a little bit about our donors as a not-for-profit. So 3 out of 4 dollars that we have in our budget comes from donors. And so it's because of the generosity of donors before you that we can offer events such as this at no cost to you. So when we do send out our evaluation and our email following up, there will be a link to our website for a potential donation to our organization. And so we just ask that you would consider donating to us to support us in the work that we're doing. Next slide. And I've already mentioned a bit about our resource centers where we have staff across the province. Our provincial office is in Regina, but then we have 7 resource centers across the province, as well as a dementia helpline. In 2019-2020, we served over 3,000 people in 290 communities across Saskatchewan. And so again, if you have questions, please don't hesitate to reach out to the Dementia Helpline or to one of the resource centers. We're open Monday to Friday, 8:30 to 4:30. So at this time, I'm going to turn it over to Jennifer, I believe. Next slide, if you like, just their questions. So I'm going to mute myself and Jennifer is going to manage the questions that we have, and we'll go from there.
Okay, hi. So you spoke about physical pain, but someone's asked the distinction between the physical pain and how to tell if it's physical or emotional pain, grief or depression. And then I was wondering maybe if there is a tool that would be able to measure if it was a physical pain or more of an emotional pain.
Yeah, that's an interesting question that I get asked a lot. And my response is that pain, whether it comes from a physical trigger or an emotional trigger, it lights up the brain in the same way. So that's why pain is defined as that sensory and emotional unpleasant event. So people like to think of pain and separate out that physical and emotional components of pain. And that really does stem back to the Rene Descartes and the dualism of trying to think that the mind and the body are separate, and they're not. The body is a vehicle for the mind, and so it's hard to differentiate physical from emotional pain, but I understand what the question is asking more about those emotional triggers. And of course, if it's an emotional trigger for something, or grief or distress about something, that, you know, heartbreak causes pain, it causes a physical sensation of pain, even though it's an emotional trigger, and you would treat that differently. But again, that speaks to the fact that when we talk about pain treatment, we shouldn't just automatically assume that it means treating the body. We need to treat the whole person. And so if it's a physical cause, of course, you're going to address that. But if it's an emotional cause or a physical cause, you're going to be engaging in different psychological strategies and different physical strategies. So for example, depression is a great treatment. There's great treatments for depression that are very similar to the treatments for chronic pain. In fact, for certain types of pain, we treat pain by treating with antidepressants. But also things like being physically engaged, like physical activity, regular physical activity, making sure sleep quality is good, social engagements, distractions, things like that would be beneficial treatments for depression or emotional distress, but also they would be even if it was like an arthritis or some other type of pain that has more of a physical trigger for it. So yeah, that whole trying to split, I encourage you to try and intermesh emotional and physical pain together, because it really is impossible to differentiate the two. And there aren't any tools to identify an emotional trigger of pain that I'm aware of. We really just look at those, either the self-report or the behaviors to identify what's happening. You may not get the same types of behaviors with an emotional trigger. You might get more social withdrawal or change in eating and sleeping, those kinds of things, as opposed to more the physical guarding or limping or splinting. So you might see some different behaviors. But yeah, it's difficult to differentiate. And again, if it's an emotional trigger for pain, you may not be treating with Tylenol and acetaminophen or NSAIDs or things like that. But yeah, that's the difficulty of differentiating different types of pain in people who can't self-report. And again, why family caregiver family caregivers being involved in the decision making is so important, because they may be able to say, well, that's how my dad behaves when he's feeling sad, versus that's how my dad behaves when his back is acting up. Family caregivers can usually identify, or tend to be a bit more familiar with the differences in those behaviors.
Well, thank you. Now, this is a bit of a specific question. You spoke about neuropathic peripheral pain, and you mentioned carpal tunnel. So I think that's maybe where this question falls. It's about that tingly pins and needle feeling that you get in your hand. The asker kind of asked maybe where that kind of pain came from. And then I'm wondering if there's, as your physical therapy brain, if maybe there's a strategy you could suggest to alleviate that kind of specific pain.
Yeah, well, and again, I'm hesitant to recommend any treatments because, well, I can't even see you. So, you would want to get, for specific advice for your type of pain, you would want to get someone who can do an assessment and determine whether it's one type of pain or another. My sister calls me up and says, okay, I need you to diagnose me. And I'm like, well, you're out in Ontario. I'm having a hard time. And I usually Zoom with her and get her to go through all these movements, and I can try to patch something together. But there's really no substitute for having somebody who can ask specific questions and see your movement, your range of motion, things like that. So, I mean, I could, if you're having, it depends on where that tingling is. There's, usually some stretches that you can do to try and give some extra space for that. But I'm really hesitant to recommend anything specific for a specific type of pain, just because I can't do an assessment on you. But I do encourage you to talk to your family doctor and see if you have a community physical therapist or occupational therapist, to seek out care. If you want more information on that, you can go to the SAS Pain website, because we do provide links for or information about physical therapists in Saskatchewan and chiropractors and massage therapists. So those types of treatments may help with that. But yeah, talk to your family doctor too. There may be some medications that are appropriate, or thermal applications, or different movements that can stretch the nerve. If there's a nerve compression, you do want to get that addressed, especially if there's any loss of strength or any loss of sensation. You don't want to ignore that, because if you leave a pinched nerve, the longer you leave a pinched nerve, then usually the more permanent the problem becomes. So make sure you get it checked out and addressed. Not right now, but in the next little bit, you need to go in. Next few days, you need to go in, or next couple of weeks, depending on how severe it is and how whether there's any of those changes in strength or sensory loss, that kind of thing.
Wonderful. Those are the questions that I have right now. If anybody has any more questions, please feel free to write it in the chat pod, in the Q&A section. Yeah.
Dr. Tupper, I'll just talk a little bit here before we wrap up then. If there aren't more questions, that's sometimes a really good sign. Obviously, you've shared enough knowledge with folks, which, you are such a wealth of knowledge, and we just really appreciate you being able to come and share that with us tonight. The brain is such a complex thing, and the whole topic of pain is so complex as well. But you've certainly taken what is very complex and made it a very interesting evening for us. So I really thank you for that. It's greatly appreciated.